Hi, everyone. Welcome back to another episode of the Horty Springer Health Law Expressions podcast.
Back by popular demand, we have the dream team here today. I'm not talking the 1992 U.S. men's Olympic basketball team.
Nobody thought you were?
I'm Hala Mazoffer, and this is my fellow associate, Mary Paterni.
Hello. Hey, we have some fun things to talk about today.
We do. I think so.
So, last time we were together for a podcast, I called you the Lean Mean Health Law Machine, if you recall.
That is correct. A name that has not stuck.
No. Shoot, one day it will. So, recently, CMS, very busy during the fall, they published their outpatient prospective payment system final rules. Now, within those final rules are brand spanking new conditions of participation relating to OB services. So they're not updates. These are entirely new, a new area that we're treading upon and that we wanted to kind of touch base with our listeners today and talk a little bit about and what they can expect and what they should be preparing for in the years to come.
Exactly. So to get us started, I think it's important that we first address what are the conditions of participation, whether you know them intimately or you just kind of have a loose sense of what they are.
I know nothing about them, honestly. I'm telling you. You know everything. Please tell us.
Appreciate that, Mary. So conditions of participation are basically their namesake. CMS has these conditions, and if you want to participate in the Medicare program, which most healthcare facilities do, you have to meet and continually meet these requirements. Now, this is for participation in the Medicare program, but these apply to all patients. So the hospital just has to have these requirements, and you can't just apply them only to your Medicare patients. They apply to all patients. So all patients get to benefit from those rules of participation.
So when you're operating your hospital, you have to meet these essential rules if you want to be reimbursed under Medicare.
Exactly. Right. And now there's a lot of different types of conditions of participation. So they break them down by service or department, and they're very process oriented. So for instance, if your hospital provides emergency services, there are specific requirements that you have to meet. So you have to make sure that your emergency services are under the direction of a qualified member of your medical staff. The emergency services have to also be appropriately staffed, and you also have to meet those requirements of EMTALA. So they have these for every different service line that you have to do. So these OB1s are now their own kind of conditions of participation that those that have OB services or everybody that participates in Medicare are going to have to make sure that they're complying with. And CMS, obviously, the big question is how do they know that we're complying with these? And CMS has two different ways that they do this. So one, they can send state surveyors to your facility to basically make sure that you're meeting these conditions of participation. Or they can use those accrediting bodies that, like the Joint Commission or the DNV, that come to your facility and make sure that you're meeting their requirements. Because the Joint Commission and DNV, don't exactly have the same conditions, same requirements as those conditions of participation. They mirror them pretty well, or they go a little bit farther than those.
Yeah, sometimes they exceed the conditions.
Exactly. Right? Now, I know you're thinking, Mary, when I think Medicare patients, I don't exactly think of obstetric services falling under kind of that patient population. So how did this kind of come about?
Well, so first off, let's take a step back. CMS is going to have broad authority to establish health and safety regulations, including requirements for pregnant patients or recently pregnant patients. And I think, at least this is what CMS is saying, that the impetus for implementing these rules and regulations is the maternal health crisis in the United States. This is nothing new. This is something that has clearly been ongoing. It has a history in our nation, but CMS is kind of finally catching up with it and saying, hey, we need to do something about that.
Yeah, I don't think that's any surprise. I think the statistics say somewhere that I think in the United States, 22 in every 100,000 women actually die during the pregnancy or the birthing process.
Which I think is higher in other high-income countries like Japan, Germany, Canada.
Yeah, so other high-income countries, they fall right around that 9 out of every 100,000 patients, which doesn't seem like a lot, but it really is when you add up those numbers.
I mean, 9 every 100,000, 22 to every 100,000. There's something going on here.
It's a big difference.
It's a concern.
Especially in such a developed nation. It's surprising.
Yeah, and I think CMS calls the attention not only to that, but they also point out that certain demographics, Black women, Pacific Islanders, Indigenous women, Alaskan Native women, studies have found that they are 2 to 4 times more likely to suffer pregnancy-related complications and even death than non-Hispanic white women.
Yeah, and I think that's related to those morbidity issues and just certain systematic issues like access to care and things like that.
Right. So I would say the new conditions of participation, these new OB rules, I think when we were talking offline, we can kind of break them up into 6 different umbrellas.
Yes. So the first big one that the CMS addresses is that organization and staffing requirements. So it's general and there's a little bit more specifics in this rule. So this specific umbrella, I would say, is not something that hospitals need to be worried about immediately. And that's because this part of the rule doesn't become effective until January 1st of 2026.
Okay, so they have some time.
They have some time. So this is a bigger rule. It's a little bit more extensive than the other ones. So you have a whole year to catch up to that requirement. So basically, they're just saying that these OB services are going to be well organized and provided in accordance with nationally recognized standards of practice of physical and behavioral health for pregnant women or women that were recently pregnant. Now, these standards are, I would say, kind of vague. So CMS isn't requiring hospitals to meet any kind of specific standard.
Shocking.
Yes, but they say that hospitals are just going to have to provide proof that they are relying on at least some kind of evidence for these standards that they're setting out. And the organization and the standards that hospitals set are going to have to factor in that mental health and substance use disorders with pregnant patients. And then also, if a hospital has inpatient and outpatient OB services, you're going to have to make sure that the quality of care is equal for both.
Yeah, and I think in the comment section of these rules and regs, there are of the new final rule, there is, while they say we're not going to require you to meet one specific national standard, but they do provide a list of resources that you can access to kind of figure out what those national standards are and how they're going to fit within the operations and the culture of your own hospital and the demographics that you work with.
Yeah, so you're not out on your own there. They give you some guidance, but you do have that flexibility.
Now, another requirement that I noticed listed in the new rules under that organization and staffing umbrella is integration, that CMS is going to now require that the OB service within the hospital be integrated with other departments. And that's because they want to make sure that the patients who are receiving OB services have access to the full extent of the services that are being provided at that hospital. Now, you might already be doing this. If so, great job. You're already ahead of the curve. But we're talking about lab, we're talking about surgery, we're talking about anesthesia. They want to see the OB service somehow integrated in with those other departments to ensure that those patients have quick access, especially in emergency cases, to other departments. And, you already have this when it comes to outpatient services and emergency services. So what you're already doing in those departments, that is something that you want to mirror in the OB world as well. And another thing under the same umbrella, CMS wants to make sure that the OB unit or your OB service is being supervised by a practitioner who has the necessary training and education and is, privileged or not necessarily privileged, but they have the training and education to supervise an OB unit. That can be an RN, a certified nurse midwife, a PA, a nurse practitioner, or an MD or a DO. Now, again, maybe this is something that our listeners are already doing.
Yeah.
But CMS mentioned in their comments that they just wanted to make this a requirement and put it in black and white, and wanted to also recognize that there are other practitioners other than physicians who can serve in this supervisory capacity as well. That does not mean, and CMS was very clear, that does not mean that the individual who is in charge of supervising the OB unit needs to be there 24/7. But they do want to have someone in that supervisory role on that unit.
Now, you named a couple different types of providers, but what about somebody, I would say like doulas that are kind of becoming more and more introduced into hospitals?
So I feel like I've come across this question a few times. I don't know if you have.
Uh-huh.
Doulas are becoming more and more of a presence in hospitals. I think more women are relying on doulas to be their advocate and to serve as their representative, especially when they're coming in with certain birthing plans, or they need someone there who can support them and guide them through their pregnancy and their delivery. Doulas are not, and I should mention that actually in these rules, in this final rule, CMS, has a nod to doulas and recognizes that they can improve pregnancy outcomes, and that there's nothing in the conditions of participation that would restrict hospitals from utilizing doulas. The one thing that I would say is that doulas are not quote unquote healthcare providers. They're not medical professionals. So you're not going to privilege a doula. They're not going to be providing a medical level of care in your hospital, or at least they should not be, because they are not licensed to do so. But so you can have doulas in your hospital, and I've come across a few hospitals who are starting to welcome doulas into their hospital and employ them. I would say that, it's advisable to maybe incorporate or adopt a policy on doulas and exactly what they are permitted to do in the hospital. So obviously they're not going to be the one who is going to be delivering the baby. You are going to leave that to the individuals who are privileged in the hospital to do so. They really are there to serve as an advocate for the mom.
That makes sense. Yeah. And backpacking off of that privileging requirement too, under the same organization staffing requirement, CMS also says that providers that are going to be providing those OB services are going to have to be privileged like all other providers. And you're probably thinking, like this is already a requirement, like we know this. And CMS recognizes that, but they just want to make this special call out here so that it's very clear that anybody providing OB services needs to be privileged to provide those services in the same fashion that you privilege everybody else.
Right. And so everything that we were talking about just now, that is going to fall under the organization staffing umbrella, that organization staffing requirement. Those requirements are not due, that they are not going to come due until January 1st, 2026.
Correct.
So moving on, there's another umbrella. That's the delivery of services umbrella, delivery of service requirements. Again, this requirement also is not going to come due, or is not going to go into effect until January 1st of 2026. So we have another year to prepare to implement this requirement as well. So under this specific requirement, CMS is requiring basic equipment for treating OB cases. They want to make sure that that equipment is kept at the facility and readily available should it be needed in an OB case. I believe in an earlier iteration of these rules, it was proposed that the requirement be that this equipment be accessible in every labor and delivery room.
I did see that, yes.
I think they've started to walk that back, understanding that not all hospitals are the same. And so really what the requirement is we want to make sure that you have this equipment in your facility and it is readily available should you need it. What type of equipment? They give examples. They're not saying that you have to have these specific things, but they're using examples of, a call-in system, a cardiac monitor, a fetal Doppler or a monitor. So those are a couple of examples. Now, they can be maintained on crash carts. I think they also use OB emergency carts, or if you have an OB hemorrhage cart, that equipment can be held in those areas. But what you should have and how much of it you should have is really going to be dependent on the scope of the treatment that you're providing, the complexity of that treatment, as well as the volume of cases that you see. So if you are, for instance, a high volume, high acuity hospital, then CMS actually uses you as an example. And for those high volume, high acuity hospitals, CMS would say, hey, maybe you should consider having this type of equipment in every labor and delivery room. But that's not going to necessarily be the same standard that they will have for other hospitals, let's say critical access hospitals or a smaller rural hospital might not need to have that amount of equipment in every labor and
depends on the hospital.
Exactly. And another thing that they want to make sure of in the same area of having equipment, they want to make sure, or another requirement is that the hospital have appropriate equipment and protocols in place in accordance with national standards again, and they provide a lot of sources that you can go and look at for dealing with emergency cases and complications. Examples: defibrillators, local anesthesia, ambu bags, oxygen, anti-epileptics. Those are just a couple of examples. Again, CMS is requiring that you have this equipment and protocols in place for dealing with emergency services, dealing with emergencies and OB complications, and that you also have trained your staff regarding those protocols as well.
All right. So now the next big umbrella that CMS has is staff training requirements. And this, unlike the last two umbrellas, these rules don't go into effect until January 1st, 2027. So we've got an extra year to kind of...
2 years.
2 years to get up to speed on this one.
2 years goes fast, though.
It sure does. It sure does.
Don't sleep on it.
No. So this is still something that you're going to want to start developing, because staff training requirements is something a little bit more involved, I would think. So hospitals are going to be required to develop policies and procedures to ensure that the relevant staff that are dealing with OB patients are trained on topics aimed at improving delivery and maternal care. So this is going to be required kind of twofold. So for those newly hired people that come into the hospital, they're going to have to get some kind of initial training to make sure that everybody's getting the same training at your facility. And then in addition to that, every provider that provides OB services at your hospital that you've identified as OB providers are going to have additional training every 2 years. And what that training is, you have a lot of discretion and you have a lot of flexibility depending on what your hospital wants to address. But this is going to be required every 2 years.
So it seems to me like a lot of these requirements that are being put out at this point with the new OB rules, it's kind of like, here's what we're requiring, here's here's what you have to do, but there's some flexibility in how you do it.
Yeah, I got the sense, a lot of flexibility in what they want, whatever your hospital, because obviously not every hospital has the same type of resources and access or deals with the same patient population. So you have that flexibility to address the maternal care that you need for your patients. Now, the next umbrella that has to do with that quality assessment and performance improvement program that most hospitals should already have if they're participating in Medicare. And now this requirement, again, goes into effect January 1st, 2027. So again, 2 years, but like Mary said, 2 years goes fast. So for here, hospitals are going to have to use their QAPI programs to improve health outcomes and disparities amongst OB patients.
And that's the Quality Assessment and Improvement Program.
Quality Assessment Improvement Program, yes.
I always call it CAPI.
CAPI?
Yeah, maybe that doesn't make sense, but I refer to it as CAPI.
I'm going to go QAPI. But basically, this is the first time that your QAPI program is going to be used to address health disparities. So it's kind of cool. Now, when you read through this, there were a lot of comments on this section saying that CMS has already used a couple of other measures to address kind of health disparities in maternal care. But CMS made it very clear that these aren't meant to be like an overlap or a duplicate of what they already have, but they're meant to be like complementary, so kind of supplement what they already have. And now this rule gets a little bit more detailed, so we wouldn't do it justice, getting how far into detail.
We need another podcast.
Another podcast entirely.
Maybe they'll invite us back.
The dream team comes back.
Yeah.
But basically, we would need just a lot more time to get really deep into the specifics of what they're going to require you to use, how they're going to require you to use QAPI program.
But the thing that we want to hammer home is they want you to start incorporating OB services into your CAPI program.
Yes, and the CMS describes this QAPI program or CAPI. But they basically lay out what they're going to want you to track and keep tabs on as a part of this program.
So, number 5. So we've gone through staff training, we've gone through the equipment requirements, we've gone through staffing requirements. Mm-hmm. Now we're going into emergency services readiness requirement.
Now this is one you want to pay a little bit more attention to.
Why? If you haven't been paying attention yet, tune in now. They've revised the emergency service readiness conditions of participation to require, they want hospitals to implement certain procedures and protocols and ensure that they have provisions in place for treating emergency services, including pregnant and postpartum patients. Now, CMS in these rules, they specify that these protocols should address obstetrical and postpartum emergencies, even if the hospital does not necessarily provide OB services, but they still have an emergency department. They want to make sure that you are adopting protocols and procedures and having those in place to anticipate emergency cases for pregnant or recently pregnant women. But they clarify that, this isn't necessarily a rule that is specific to OB services. They're kind of just calling it out more. But they want to clarify that this requirement is not just for OB patients, but for all patients as well. But they really, because this is the theme of the day, or the flavor is OB, they wanted to call that out as well. So again, CMS uses we want your policies and procedures regarding emergency preparedness to reflect national standards. Again, it's going to look different for every hospital. But some of the supplies that they recommend that you include in your emergency readiness provisions are blood products, life-saving biologicals, and other types of life-saving equipment, of course. And then again, going back to staff training, they want to make sure that all staff are trained on this and they actually receive annual training regarding these emergency protocols as well. Now, this in some way, shape, or form, it differs from EMTALA. Because under EMTALA, the hospital, you're required to screen for emergency medical conditions. And if one exists, you are to stabilize the patient. EMTALA does not, according to CMS, according to the comments in CMS, what they're saying is the way this differs is that EMTALA does not directly address emergency department readiness, however. And so that's why they feel the need to revise these requirements or implement these new rules to kind of fill that gap, especially when it comes to obstetrical, geriatric, and pediatric populations. They want to make sure that every hospital who has an emergency department is prepared or is ready for those types of complications. So they're hoping that this final rule will kind of bridge the gap with the hole that they believe EMTALA leaves open.
That makes sense.
Yeah. And then one other, number 6, the final umbrella is the transfer protocol requirements. Now, this is one, and I should take a step back. So the emergency readiness and this transfer requirement, the transfer protocol requirement, both of these are going to go into effect July 1st of 2025.
So this is why you want to pay a little bit more attention to this one.
Oh, okay.
Yeah, 6 months goes a little
I just thought you were more
faster than
interested in this topic. No, yeah. I left that part out at the beginning. Bury the lead here. This is going to go into effect within the next 6 months. So July 1st, 2025, CMS is expecting that hospitals comply with both of these conditions of participation or these rules. So under the transfer protocol requirements, CMS is requiring hospitals to have written policies and procedures for transferring patients under its care. And that even includes intra-hospital transfers, as well as transfers of hospital inpatients. So that would be, for example, transfers from the emergency department to inpatient, transfers between inpatient units in the same hospital, transfers between inpatient units at different hospitals. They want to make sure that hospitals and their emergency departments have some protocol in place and step-by-step process of how that's going to look. And again, they want to see that you're training your staff on those transfer protocols.
Yeah, so all of these requirements that will eventually be their own conditions of participation. The rule becomes effective January 1, 2025, but as we've talked about, there's kind of like a staggered implementation of all the specifics. Now, given the most recent Loper Bright case that made its way through the Supreme Court, there's a lot of speculation out there that possibly these rules are going to get challenged, since that kind of gives CMS the basis to put out these kind of rules. But like we've been talking about, time goes fast and you can't guarantee like something that is going to happen. So we offer all hospitals that participate in Medicare, you need to look at these rules and see how they apply to your facility, especially for those hospitals that offer those specific OB service lines. So this isn't something to wait on, but to get started on as soon as possible because it takes some time to work your way through the magic of the hospital. So thank you for joining us today. If you have any,
Thanks.
thank you. If you have any questions, please email me or Mary.